I'm Dr. Neil Skolnik, and today we are going to talk about the American Urological Association's guideline on the early detection of prostate cancer. This guideline gives us the opportunity to revisit prostate cancer screening with PSA, something that we've not talked about in a while. Before I go over the AUA recommendations, I want to remind people about the context in which this recommendation is being released. And that context is that there's just an enormous range of recommendations from different organizations recommending different things. On one end of the spectrum is the American Academy of Family Physicians, AAFP, which does not recommend routinely discussing PSA-based screening if the patient does not request it, and goes on to say for men 55 to 69 years of age who are considering periodic prostate cancer screening, physicians should discuss the risks and benefits and engage in a shared decision making that enables an informed choice. And they give that a grade C recommendation. They recommend against screening men older than 70. A guideline from BMJ says, quote, a weak recommendation against offering systematic PSA screening, unquote. The American College of Physicians recommends that clinicians inform men between ages 50 to 69 years about the limited potential benefits and the substantial harms of screening for prostate cancer, and goes on to state that screening should not be done in men under 50 or over the age of 69. We're going to discuss the USPSTF recommendations a little more in a little bit. So this is the context in which the AUA guideline has come out. As is true of all the guidelines, the AUA guideline is explicit about the challenges inherent in PSA testing, which is to identify clinically significant prostate cancer while minimizing the harm caused by detecting cancers that would never otherwise have become manifest. Let me go over the recommendations. I think you'll see some helpful information, and you'll also note some obvious differences in the recommendations between the AUA recommendations and other groups. For starters, all the groups agree. The AUA guidelines emphasize shared decision-making because screening is truly, and the term is great, a preference-sensitive decision. Essentially, this means which do you fear more, the risk of prostate cancer or the risk of side effects of treating a cancer that may never have caused you a problem? Okay, important. A critically important recommendation they then make is that for people with newly elevated PSA levels, and this is really helpful to us, clinicians should repeat the PSA in a few months before any further screening or diagnostic testing is done. This is because 25 to 40% of elevated PSAs are normal on retesting. The guidelines then discuss the issue of what level of PSA should be considered elevated, since PSA normally increases with age. While they don't give specific recommendations here, they discuss that studies that identify age-specific thresholds for elevated PSAs use greater than or equal to 2.5 nanograms per ml for people in their 40s, all the way slowly increasing to greater than 6.5 for people in their 70s. I don't think that most of us in primary care will remember the exact thresholds, but what I think is critically important is to recognize that for younger men, the usual number of 4 is not a line in the sand, and you may think about referring at a lower PSA level. Next up. The guidelines give a conditional recommendation that we may begin prostate cancer screening and offer a baseline PSA to average risk men ages 45 to 50. For people at increased risk of prostate cancer, so that would be Black ancestry, strong family history, or other strong risk factors, the AUA makes strong recommendations that screening should be offered beginning at age 40 to 45. After a first test, the guidelines strongly recommend offering regular prostate cancer screening every 2 to 4 years from ages 50 to 69. Again, I want to point out that this interval, every 2 to 4 years, provides helpful guidance if we and our patient chooses to proceed with screening. The guidelines suggest a flexible age can be used to discontinue screening and to think about this at age 70 because the risk of overdiagnosis of non-clinically significant prostate cancers increases with increasing age. Let me now point out some differences from the USPSTF 2018 recommendations, which are in the process of being updated. Where the AUA recommends to start offering screening at age 45 and 40 for those at high risk, and then every 2 to 4 years from age 50 to 69, the USPSTF gives a grade C recommendation to start discussing screening at age 55 and continue through age 69, and then it recommends not screening men above 70. While USPSTF acknowledges the increased risk in some groups, including those with a family history of prostate cancer and African American men, for those two groups, they say, and this is a quote, the USPSTF is not able to make a separate specific recommendation on PSA-based screening. To round out our comparisons, the American Cancer Society recommends discussing screening starting at age 50 for those at average risk and 45 for those at high risk. Finally, the AUA guidelines clarify that a rise in PSA level over time, often referred to as the PSA velocity, should not be used as the sole indication for further evaluation of prostate cancer. This is a lot of conflicting information among different organizations, and that information has changed over time. See my essay in JAMA Internal Medicine on this issue. This is really important information to understand. It comes up all the time with our patients. I'm interested in your thoughts on this topic. Please leave them in the comments section below. I'm Dr. Neil Skolnik, and this is Medscape.